Good day. Today we are discussing normal labor in obstetrics. I am Kike Additional. I'm a fellow of West African College of Surgeons and the National Postgraduate Medical College of Nigeria. I'm also a consultant obstetrician and gynecologist at the University of Ilorin Teaching Hospital and an associate professor in the department in the same university. Our learning objectives include ability to define and diagnose labor and its stages at the end of this lecture, to identify the components of normal labor, describe mechanism of labor, and use the WHO pathograph to manage labor. So what is labor? Labor is a physiologic process during which the fetus, membranes, umbilical and placenta are expelled from the uterus through the vagina. That is, the products of conception, including the fetus, are delivered via the vagina. It is actually defined as the onset of regular, rhythmic, and painful uterine contractions, leading to an eventual dilatation and effacement of the cervix, with, of course, subsequent expulsion through the vagina of these products of conception. I want to take note of the following terms: the onset of regular, rhythmic, and painful uterine contractions, the eventual opening of the cervix, that we can simply say to be dilatation, and the effacement, which is the taking up of the cervix to become part of the uterus, such that the fetus and other products of conception can be expelled to the outside world per vagina. So, labor comes in stages, and the stages are actually a continuum. The stages are divided into three. We have the first stage, the second, and the third stage of labor. When there's the onset of the contractions that become regular, rhythmic, and painful, to that point in which the cervix, that the opening in the uterus, the mouth of the uterus, becomes completely, fully dilated at 10 cm, we talk of the first stage of labor. This first stage means that from onset of uterine contractions to the point at which the cervix is fully dilated at 10 cm. It is also divided into two phases. We have the latent phase and the active phase. Why is this important? Because the latent phase is characterized by irregular contractions, even though there is progression and there is progressive dilatation of the cervix. But when examined, it is less than 3 cm in dilatation. By the time the cervix in this phase or in this stage becomes 4 cm dilated, we expect a progressive dilatation of the cervix and further descent of the presenting parts of the fetus. So, we talk about the next stage. Remember, I said it's a continuum from the first stage to the second stage. Second stage starts from that point of full cervical or complete cervical dilatation to the delivery of the fetus. This usually lasts 2 to 3 hours too, but there is a division in terms of whether the patient is a nulliparous or a multiparous patient. For the nulliparous patients, this takes a bit longer. Without any regional form of anesthesia, it should not exceed 2 hours, while with regional anesthesia, this takes 3 hours. While in the multiparous patients, this ordinarily too should not exceed 1 hour in the absence of regional anesthesia, but with regional anesthesia, this may take longer, 2 hours, but should not be more than that. So, what are we saying? That the second stage of labor should not last more than 3 hours in the nulliparous on epidural, and not more than 2 hours in the multiparous on the same kind of analgesia in labor. Then we move to the third stage of labor. That is the stage in which after the delivery of the fetus, there's the delivery of the placenta and other fetal membranes. This is the third stage of labor. This usually lasts 10 minutes and is considered prolonged if it lasts longer than 30 minutes. So, we have tried to look at labor as a physiologic process. So when do we say labor is normal? Most times we're able to say labor is normal after delivery of the fetus and the product of conception. Why? Because we consider it to be normal when it is, number one, spontaneous in its onset. Contractions are regular, rhythmic and painful. At the start of the labor, it is low risk and it remains so throughout labor and delivery. Then we say that labor actually was normal. The infant is eventually delivered spontaneously in the vertex position at term, that is between 37 and 42 completed weeks of pregnancy. So normal labor is considered a retrospective diagnosis after we have included some important factors: the spontaneity of its onset, the regular contractions with eventual cervical dilatation, and delivery of the fetus per vaginum. Then we say that labor it's normal and it occurs at term. So when we look at this, we need to consider another important section when we discuss labor. So what do we describe as the mechanism of normal labor? Mechanism of normal labor is divided into 7 definite sequences, and it is assumed on the premise that we are talking of a fetal presentation that is normal, that is cephalic vertex presentation, and the lie is longitudinal and of course in a well-flexed attitude. So sequentially, what does it involve? The first thing usually is engagement, followed by the descent of the presenting part, afterwards the flexion, internal rotation, then the 5th is extension, the 6th being restitution and external rotation, and final expulsion. So what do we define as engagement? At this point, I would like you to refer back to that picture of the fetus that is presenting cephalic and is flexed, well flexed, where the presenting diameter is the biparietal diameter in a well flexed head. So when the widest diameter of the presenting part has entered the maternal pelvis below the pelvic inlet, we'll talk about engagement. That is engagement of the presenting part. When the largest, that's the widest diameter of that part, has entered into the maternal pelvis below the pelvic inlet. When such patient is examined, you will find that on abdominal examination, you will find that 2/5 of the presenting part, which is the head here, will just be palpable per abdomen, while the other 3/5 has entered into the pelvis, meaning there will be no reversal back. Also, on pelvic examination, this will be felt at the ischial spine as station 0, at the level of the ischial spine, that's station 0. The next after that is the descent. Of course, with uterine contractions and further descent, there will be downward movement of the presenting parts, because the aim of labor is to deliver, is to expel the fetus into the outside world per vagina. This occurs with contraction, so we talk about the descent as the next stage. This is closely followed by flexion. Flexion means that there is passive flexion of the occiput as it hits the pelvic floor. So what does that mean? It means that as the well-flexed head hits the pelvic floor, it becomes better flexed on the chin or it becomes better flexed, such that the chin on the chest converts the presenting parts into what we call sub-occipitobregmatic diameter, which is lesser than the sub-occipitofrontal. That is, it is now reduced from 11 cm to 9.5 cm. This is very important because with that contraction, as the head hits that, the occiput gets flexed better and a lesser presenting diameter occurs with flexion. Afterwards is the internal rotation of the head. As it descends, the presenting part rotates from its transverse position. So remember, there was an engagement. So it rotates from the transverse position to become anteroposteriorly through a 45 degrees rotation under the symphysis pubis. So this makes the anteroposterior diameter of the head, the presenting part, to become aligned with the anteroposterior diameter of the pelvic outlet. So that is what internal rotation does. It turns it from the transverse position to become to become positioned anteroposteriorly for further, as the head descends, and for further delivery. Afterwards, after this flexion, the next sequence is extension. In extension, the base of the occiput in this well flexed head comes in contact with the inferior margin of the symphysis pubis. So with this, there is what? There is extension and rotation around the symphysis pelvis, and it is the extension of the head that delivers the fetal head, and that is what is seen. Don't forget that all these occur with further descent and uterine contractions. Finally, after the delivery of the head by extension, there is the realignment of the original anatomical position in relation to the body. It was initially transverse, became anteroposteriorly rotated. The body is still in that posture. So there is restitution of the body to align anatomically with the other parts of the body, especially the shoulders. So with expulsion of the fetus, there's conclusion of the delivery process in the order of the anterior shoulder, followed by the posterior, and then the rest of the fetus. So we talk about the issue of from that time of engagement to the descent to the interrotation flexion, such that the head is now delivered in first with the head is delivered by extension. There is expulsion of the fetus after the restitution, and the order of delivery will now be the shoulder, the anterior shoulder first, the posterior shoulder, and the rest of the fetus. This, I would say again, helps us to remember that we're looking at a normal presentation, vertex, well flexed head, the baby in a good attitude, undergoing these sequences. So how do we monitor labor? Well, we monitor labor by looking at contractions, yes, but we need a tool that we can use to objectively define the progress of labor, and that takes us to the pathograph. So the pathograph is a paper-based tool. It's a tool used to monitor labor. It was first introduced by Friedman in 1955 and further modified by Philpott and Castle in 1972. In summary, it can be defined, the pathograph can be defined as a composite graphical analysis of maternal and fetal intrapartum parameters to evaluate progress of labor. And what is done is that these parameters are entered against time on the chart, on the graph. This is an example of the WHO pathograph. This is what is currently recommended for monitoring labor. What are the components of the pathograph? The pathograph has sessions for the mother, for the fetus, of course for the progress of the labor, and other events occurring in labor, such that when you pick up a pathograph, you can give a summary of the labor labor of the patient. So important components are the maternal identification in terms of the name, the age, the parity of the patient will be put in place. The fetal portion includes the fetal heart rate, the color of the amniotic fluid, and molding of the fetus skull. And there's a portion of that we call cervical. I will talk about this as we go on. The cervical dilatation and the fetal descent. Maternal events there will include uterine contractions, oxytocin use, maternal vital signs, and urine output. What are the benefits of using the partograph? The partograph is very important, as I said. That is good for routine monitoring of labor, its progress. It's important because it monitors labor. You identify any slow progress so that you can intervene or do what to stop other complications of labor. For example, it prevents prolonged and obstructed labor. And this helps to prevent other complications that can result from labor being prolonged or obstructed. It also helps to recognize early fetal problems and prevent neonatal complications during the course of labor. With use of the partograph, they were able to also further reduce the rate of cesarean section. So how do we plot a partograph? I've mentioned earlier the components of a partograph. We referred to this one earlier. The components will be entered. These components need to be entered basically legibly. It should be done legibly because it's a record of care in labor, and this can become a medical legal document in the future. So it's important to know to enter the patient's identification, admission details, including dates and time as soon as practicable, so that these things are not missed out, so that you can know the progress of labor, the timing of the events that are monitored. We should understand that there are full vertical lines on the partograph as the partograph, and on that sheet, each vertical line represents an hour line. So with that line, you can know the exact time of your first observation, and we can now fill the time scale along the top of the partograph. So the vertical line with the hour line, you can do that. You can see the time scale put along the top of the partograph. We'll see this in the example given. Under the partograph, we have the maternal, the fetal, and the labor assessment that we need to do. On admission, although this is not chronologically, but these are the things that we do when we admit patients. After taking a good history, after you have taken the history of the labor, the onset of labor, and other parameters, and the past, the pregnancy history and the past obstetric history in this patient, we also want to note on the partograph, in addition to the identification, the maternal blood pressure, pulse, temperature, the vital signs that can be recorded. And this can actually be recorded on the partograph. There is a portion to record the systolic blood pressure, and the sign is given there, as well as that of the diastolic blood pressure. The pulse rate should be recorded with a period. That's the same way the fetal heart rate is also recorded with a black dot. This is shown here. As we go on, we can now look at the other section, which we include the fetal parts. The fetal parts, the fetal parameters that will be included will be, importantly, the fetal heart rate, as I mentioned earlier. Secondly, you want to know whether the amniotic fluid, the way the amniotic fluid appears, you want to indicate whether the membranes are intact, in which case you put I to indicate that. If it's already ruptured, the membranes are already ruptured, you want to know whether the the amniotic fluid is clear, or is it blood stained. You write C if it is clear. You indicate with B if it's blood stained, and if it's meconium stained, you indicate M. The other assessment that is done on the fetus is the molding. Molding here means you want to see whether the sutures are posed together or not. Molding, no molding is recorded as 0. When the sutures are opposed, you record that as 1 pulse under the molding. 2 pulses if the sutures are overlapped but are reducible. And when there is severe molding, you'd grade as 3 pluses, and that way means that the sutures are overlapped but not reducible. The other thing you will need to put on the pathograph may be the caput, degree of caput, which you measure as whether it is present or absent. If it's absent, you write 0, and if it is depending on the degree of severity, although this one is subjective, you still increase, you write in grades of 1 plus, 2 plus, or 3 pluses. The next assessment on the pathograph is the labor assessment, which is the main thing, and this is where you assess the contractions. The contractions are recorded below the fetal assessment, and they are recorded in frequencies of in 10 minutes. You want to count the number of contractions in 10 minutes. There are 5 blank vertical squares on the pathograph to indicate contractions, and each square represents a contraction. You need to indicate if there's how many contractions in those boxes. So by the time you are getting 5, you will know that, okay, indeed you have gotten that maximum number that can be recorded on the pathograph. So you record the number, each square represents a contraction, and the strength of the contraction are shaded as whether they are weak, moderate, or strong, depending on the duration. If the contraction less than 20 seconds, may describe that as weak. If it lasts between 20 to 40 seconds, you say it is moderate, or it's of moderate strength, and it is really strong when you have contractions lasting 40 seconds or more. Anything used to aid labor at any point in time should also be entered and recorded, and there are sections for such records. The oxytocin used in units, the number of drops that you are doing per minute is also recorded, and as you titrate, you can indicate the titration on the pathograph. There's also a column for drugs given and IV fluid too that can also be recorded. The next very important, that perhaps is probably the most important part of it, is what we call the cervicograph. This is a section of the pathograph that depicts the cervical dilatation and descent of the presenting part in relation to time. So this is the actual portion that monitors the progress of labor. The mark X is used to record dilatation of the cervix against time, and the mark O is used to record level of descent in feet above the pelvic brim. So that is used to record the descent in terms of the number of feet palpable. On this same cervicograph, there are 2 lines. The lines are very, very important. A close look at the line, you will see that there's an alert line, and that line is drawn from the point of cervical dilatation on your first vaginal examination when the patient is in active phase of labor. So the alert line usually starts pre-drawn in some cases as 4 cm at 4 cm cervical dilatation, and it denotes that you expect the rate of labor to progress at 1 centimeter per hour. So the alert line differentiates slow progress from normal progress of at least 1 cm per hour. So it is assumed that if your patient maintains the charts along the alert line, that means the patient is progressing at the rate of 1 cm per hour. And this is important for us to differentiate slow from progress from normal progress of labor. The next line that is drawn parallel and 4 hours to the right of the alert line is the action line. This line is meant to indicate when you need to take intervention based on your assessment after 4 hours. It is expected that you would monitor labor, and when labor is monitored, you would be able to see where the alert line is on and the progress from what is charted. You expect a progression and the upward movement in terms of the uterine cervical dilatation, and you expect a descent of course of the presenting part with your indicator on the pathograph. So the action line, as I said earlier, is just a line parallel and 4 hours to the right of the alert line, and it helps to know when to go on and take action. This is a diagram of pathograph of normal labor, and wish to refer to one important diagram again, this pathograph. If you look at this pathograph closely, you see all that I've mentioned here. You would see the fetal portion at the upper part after the maternal identification. You would also see the portion of the amniotic fluid volume, and the and you would be able to see the cervicogram that I described, this alert and the action line. The alert line, you will see it's such that the progress of labor should go at 1 cm per hour, and then 4 hours after, next to it is the action line. So with this, we'll be able to see the portion for cervical dilatation and the descent of the presenting part. Other portions for the maternal parameters are also indicated on this diagram. In conclusion, we have discussed labor, and we have seen that labor is divided into 3 functional stages of the first stage, the second stage, and the third stage of labor. We have defined normal labor as a retrospective diagnosis that is characterized by onset of spontaneous onset of contractions, regular contractions at term, that is between the 37th and the 42nd week of gestation, with eventual delivery of the fetus and product of conception through the vagina. And we've also looked at the mechanism of normal labor as involving 7 definite sequences of engagement, descent, flexion, internal rotation, extension, restitution, and external rotation with eventual expulsion of the fetus. And finally we discussed the WHO pathograph as a graphical representation of events in labor for evaluation and monitoring to prevent complications of labor. Thank you.